Welcome to this video on acute coronary syndromes. Over the next several minutes, we will explore the spectrum of these conditions, from the initial plaque rupture through diagnosis in the cath lab to the long-term prevention plan. Let's begin. First, we will cover how to recognize an acute coronary syndrome and pin down the diagnosis at the bedside. Acute coronary syndrome is essentially one disease with three phases. A plaque ruptures, causing a clot. If it partially blocks the artery, you get unstable angina or a non-ST elevation myocardial infarction. If it fully blocks the artery, you get a STEMI. Troponin and the ECG are key to distinguishing between them. Looking at the ECG tracing helps us understand the level of occlusion. Partial blockages show ST depression or T-wave inversion, while complete blockages show ST elevation. The ECG is your first window into the severity of the arterial blockage. Why does a stable plaque suddenly become an emergency? A lipid core builds over years under a thin cap. When this cap ruptures, platelets rush in and a clot grows. Within minutes, the heart muscle downstream begins to suffer. This cascade is the engine of the disease. Two simple questions help sort every patient. Is the troponin elevated? And is there ST elevation? No to both suggests unstable angina. A positive troponin without ST elevation indicates a non-STEMI, while ST elevation confirms a STEMI, meaning the artery is fully blocked. Not every infarction is caused by a ruptured plaque. Sometimes the heart cannot meet the supply-demand balance due to issues like tachycardia or anemia. Other causes include coronary spasm, dissection, or direct injury to the muscle. Always keep a broad differential. At the bedside, listen closely to the patient's story. Classic angina presents as pressure or tightness. Also, watch for associated symptoms like nausea and sweating. Be particularly vigilant for atypical or silent presentations in women, older adults, and individuals with diabetes. Remember that a normal physical exam never rules out an acute coronary syndrome. However, if signs are present, they are significant. Findings like an S4 heart sound, crackles, or bruits can provide crucial clues to the underlying condition. Two key tests must be performed quickly. Obtain an ECG within 10 minutes and compare it to previous ones. Draw serial troponin levels to track a rise or fall, which is critical for confirming the diagnosis. The ECG also helps localize the infarct. Changes in specific leads point to different coronary arteries. For example, inferior leads point to the right coronary artery, while anterior leads point to the LAD. Identifying the territory helps predict the culprit vessel. This reference table maps specific regions to their corresponding leads and arteries. Remember, in cases of an inferior infarct, always obtain right-sided leads to check for right ventricular involvement. If you are unsure about the diagnosis, perform risk stratification. High-risk patients typically move directly to angiography. Low-risk patients can be safely evaluated with stress testing or coronary CT angiography before discharge. We will now discuss special causes, risk stratification, and the essential treatments every patient should receive. Prinzmetal angina is a coronary spasm that can cause transient ST elevation. It is more common in younger smokers. It is managed with calcium channel blockers and nitrates, while certain high-dose aspirin or beta blocker treatments should be avoided. Pretest thinking helps maintain diagnostic accuracy. High likelihood includes classic anginal pain with elevated troponin. Intermediate cases involve older patients with vague symptoms, while low likelihood cases feature sharp, positional, or reproducible pain with normal initial tests. Every patient with an acute coronary syndrome requires anti-ischemic therapy. This includes nitrates for symptom relief, beta blockers once the patient is stable, and oxygen or morphine reserved for low saturation or refractory pain, respectively. Start long-term management early with a high-intensity statin. Consider adding an ACE inhibitor or ARB for patients with heart failure, low ejection fraction, or diabetes. Additionally, aldosterone antagonists should be initiated when the ejection fraction is reduced. The foundation of therapy is dual antiplatelet treatment. Chew aspirin immediately to reduce mortality and reinfarction risk. Follow this with a P2Y12 inhibitor. Ticagrelor or prasugrel are preferred, and layer on an anticoagulant to stabilize the patient. We now move into the curriculum regarding antithrombotic agent selection and the critical decision-making process for catheterization laboratory intervention. Choosing your second antiplatelet is crucial. Ticagrelor is a common, reversible choice. Prasugrel is the most potent agent, indicated at the time of PCI, but avoided in patients with a history of stroke. Clopidogrel is an alternative when others are unsuitable. Additional tools include ticagrelor, an intravenous agent with a rapid onset and offset, useful when oral loading is impossible. Glycoprotein IIB/IIA inhibitors are now reserved for cases with a high clot burden or no reflow to minimize bleeding risk. Selecting an anticoagulant is key. Unfractionated heparin remains the standard workhorse. Enoxaparin is an effective alternative, though you should avoid switching between them. Bivalirudin is preferred for patients with heparin-induced thrombocytopenia, while fondaparinux is rarely used. In non-ST elevation acute coronary syndromes, choose between an invasive or ischemia-guided strategy. Urgent intervention is needed for shock or refractory symptoms. Early invasive management is for high-risk patients, while ischemia-guided approaches are reserved for low-risk individuals. The TIMI score effectively guides clinical urgency using 7 clinical and laboratory factors. A higher score reflects a greater risk of adverse events within 14 days, signaling the need for more prompt intervention in the catheterization lab. The heart score is a valuable triage tool for emergency department chest pain. By assessing history, ECG, age, risk factors, and troponin, it stratifies patients into low, moderate, or high-risk categories to determine if they require admission or can be safely discharged. We now address STEMI and the necessity of rapid reperfusion, where every minute saved preserves critical heart muscle function. To identify a STEMI, look for ST elevation in 2 contiguous leads, keeping in mind specific thresholds for V2 and V3. Also, consider new left bundle branch blocks or posterior wall infarct patterns as indications for immediate action. Why is speed so essential? Once an artery becomes fully occluded, the downstream heart tissue undergoes a rapid transition from ischemia to irreversible necrosis. In the setting of a STEMI, time is muscle. Know your reperfusion time targets. For primary PCI, aim for under 90 minutes at capable centers, or transfer if the intervention can be done within 120 minutes. If PCI is inaccessible, initiate fibrinolysis within 30 minutes of arrival. When it's available in time, primary PCI is the gold standard. Compared to clot-busting drugs, it significantly lowers the risk of death, reinfarction, and stroke. Even if it requires transferring the patient to a specialized center, it remains the superior strategy. If PCI is not an option within 120 minutes, fibrinolysis is the alternative. It is best used within 12 hours of symptom onset, especially for anterior infarcts or new bundle branch blocks. Be aware, however, that it carries a small but significant risk of intracranial bleeding. Before administering fibrinolysis, you must screen for contraindications. Absolute contraindications include a history of intracranial hemorrhage, recent stroke, suspected aortic dissection, or active internal bleeding. Relative contraindications, such as high blood pressure or recent surgery, require careful consideration of the risk-benefit profile. A comprehensive drug bundle is essential alongside reperfusion. This includes chewed aspirin, which should be continued even if bypass surgery is planned, a P2Y12 inhibitor given as soon as possible, and an appropriate anticoagulant to prevent further clot formation. Once the artery is successfully opened, our focus shifts to monitoring for complications. Understanding what can go wrong post-procedure is crucial for timely management and patient stability. It is important to look beyond the culprit vessel. Treating other significant lesions can improve long-term outcomes, though this is avoided during acute cardiogenic shock. In cases where the anatomy is not suitable for stenting, urgent bypass surgery remains a life-saving option. Pump failure is a serious concern. A significant number of patients may develop left ventricular failure or progress to cardiogenic shock. Following revascularization, mechanical circulatory support, such as a microaxial flow pump, can be used to stabilize hemodynamics and improve survival. Inferior myocardial infarctions present 2 classic traps. First, heart block is common because the right coronary artery supplies the AV node. Second, watch for right ventricular infarction, indicated by hypotension and clear lungs. These patients require fluid support, not nitrates. Mechanical catastrophes can occur days after an infarction. These include free wall rupture leading to sudden collapse, septal rupture marked by a new murmur, or papillary muscle rupture resulting in pulmonary edema. All of these require immediate surgical intervention. Monitor the cardiac rhythm closely. Atrial fibrillation requires rate control and electrolyte correction. Ventricular tachycardia or fibrillation should be managed per ACLS protocols. Conversely, accelerated idioventricular rhythm is a benign marker of reperfusion and generally does not require treatment. Late complications require specific management. An LV thrombus, common after anterior infarcts, needs long-term anticoagulation. Ventricular aneurysms are usually managed medically, unless they drive heart failure or rhythm issues. Pericarditis is managed with aspirin and colchicine, while Dressler syndrome is a later immune-mediated inflammation. Secondary prevention is the final, critical step to ensure long-term heart health and prevent future events. Let's review the standard medical therapy after discharge. Post-discharge antiplatelet therapy is essential. Aspirin is continued at 81 milligrams daily. AP2Y12 inhibitor is usually prescribed for approximately 1 year, with the choice tailored to the patient's bleeding and ischemic risk. If anticoagulation is required, a simplified regimen is often preferred. The cardioprotective regimen also includes a beta blocker, especially for patients with reduced ejection fraction. ACE inhibitors or ARBs are vital for those with heart failure, hypertension, or diabetes. Additionally, aldosterone antagonists may be added to further support patients with reduced ejection fraction. Finally, aim for aggressive lipid management. Target an LDL level below 55 milligrams per deciliter. Start with high-intensity statins and, if the goal is not met, add ezetimibe or a PCSK9 inhibitor. Systematic optimization of lipid levels is key to secondary prevention.